Hey team, so good afternoon, and today we're going to talk about DVT ultrasound. So in the emergency department, we rely on compression ultrasonography. This is something that takes about 2 to 5 minutes to perform. We focus in on our deep vessels at two main points, so we're focusing on the femoral veins and the popliteal veins. So remember, those are your branch points. The key here is that absence of complete compression means that there is a clot. So let's say that again. Absence of complete compression means that there is a clot. So unless you have the two vessel walls completely coming together, then you are concerned about a clot in that vein. To do this, we rely on our high-frequency linear probe to visualize our veins here. If you have a bigger patient and you need just a little bit of increased depth when imaging the veins, you can always switch to your curvilinear probe. First, we want to get the patient set up, so we want them lying semi-recumbent in their bed with their leg externally rotated at the hip so we can see the femoral vessels a little bit better, and then a slight bend in the knee to allow for imaging of the popliteal vessels. Once we have our patient positioned, so you can see here that you have the hip externally rotated and the knee bent. So right here we are scanning the patient's femoral vessels. Then we can easily move the probe behind the patient's knee to look at their popliteal vessels. If for some reason you're having difficulty scanning the patient with their knee bent like this, you can either ask them to lie prone, or you can lift up and elevate their leg off of the bed, flex it at 90 degrees, and maybe let them lay it on a stack of blankets or pillows. So going over the ultrasound, the anatomy of our lower extremities that we're going to want to ultrasound. So your common femoral vein is formed by the confluence of the superficial femoral vein and the deep femoral vein. The saphenous vein drains into the femoral vein just proximal to this bifurcation. Remember that the femoral artery that runs along with your femoral vein bifurcates into the profunda or the deep femoral artery, and the superficial femoral artery, or simply the femoral artery, then continues until it passes through the adductor magnus to become the popliteal artery. Remember that your clots are going to form at areas with high turbulence or venous stasis. So a little throwback to Virchow's triad from your first 2 years of medical school. We remember, though, that on our right leg and left leg, the artery is always lateral compared to the femoral vein, and the femoral vein is more to midline when compared to it. So that navel relationship we all spent time learning. We always want to keep the probe marker to the patient's right, whether you're imaging the patient's right leg or the left leg. So use that relationship to identify and know which leg or which lower extremity you're imaging. As we move down distally from the inguinal ligament and we're seeing the common femoral vein, we'll then see the artery split into the superficial femoral artery and the deep femoral artery. So looking at our ultrasound anatomy here, we've started in the inguinal crease and we're identifying the takeoff of the saphenous vein and the femoral artery. The saphenous vein we can see coming in medially in the top right corner of the screen and joining that femoral vein. We have the femoral artery over to the left side of the screen. Now we want to make sure that we compress the vein as we scan. So here you can note the complete compressibility of both the saphenous vein and the common femoral vein. We're also seeing, as we compress the superficial and profunda femoral artery, we're seeing the compression of the femoral vein. So can you tell me what side we're on here, which leg that we're looking at? If you said we're looking at the patient's right leg, you are correct. So now we've scanned down just probably about a centimeter or so. We've scanned distally, and we've now seeing the split of the common femoral artery into the superficial and deep femoral artery on the right side of the left side of the screen, and the femoral vein on the left side of the screen. We're still having complete compression of the femoral vein here. So starting at the inguinal ligament, holding the probe in transverse position, scanning down and compressing every 1 to 2 centimeters, looking for the saphenous vein, the common femoral vein, then looking to make sure that you have the split of the artery into the deep and superficial branches, then scanning down so that we're seeing the split of the femoral vein. So note that we have in fact changed legs here. We were scanning the patient's right leg, but now we've changed over and we're scanning the patient's left leg. So we have the femoral vein on the left side of the screen and the femoral artery that's already bifurcated on the right side of the screen. If you watch as we scan down, scan distally, the femoral vein is splitting into 2 branches, one on top of the other. Now we're taking our probe and moving it to the popliteal fossa and continuing to scan. So we're going to scan 12 centimeters superior to the knee crease down to 5 centimeters distal to the knee crease. The popliteal vein is formed by the confluence of the anterior and posterior tibial veins. The popliteal artery, though, is a continuation of the femoral artery and bifurcates into the anterior and posterior tibial arteries. Always remember that the vein is on top in the pop. So what are we looking for when we're looking at veins? Veins have thinner walled and they are supposed to be pretty easily compressible. If you're seeing arterial compression, then trust me that your compression of your vein is adequate. However, if you're not able to compress that vein, then you have a clot. So full compression of the vein is your test for patency or absence of clot. We can also use color Doppler or color flow to look for any filling or color defects or thrombus. You can augment the flow if you want to by squeezing on the patient's scaph. Thrombus may be isoechoic, which we remember is that fancy ultrasound word for appearing the same echo color as your surrounding soft tissue. So here we have an isoechoic clot that appears white inside the vessel lumen. This one is not compressible at all, and so yeah, you're pretty worried about a clot right here. They have a nice big clot in their femoral vein. Clots can also be anechoic, or we remember anechoic is that fancy ultrasound word for completely black without echoes. So you really need to rely on compressibility so you're not fooled. Compressibility is key. Note that in this particular image, color and compression help identify the clot. So we have an anechoic or completely black clot right here. It looks like a normal vessel that would probably be just filled with blood. Acute clot appears anechoic, but as we compress, we're not able to compress that vein, and we're adding on color and seeing that there's actually no color flow in that vein at all. So yikes, that is consistent with a clot. Here we can see in our popliteal fossa, we have our popliteal artery, and then we have the popliteal vein sitting right on top of that popliteal artery. Note the echogenic material inside the popliteal artery and the lack of compression. So that helps confirm that there is in fact a clot in that popliteal vein. We even take it a step further and apply color Doppler and note that there's no color flow in that popliteal vein, and we are trying to compress, unable to compress, so that patient has a clot. So to sum it all up, in the emergency department, we use about a 2 to 5 minute 2-point compression ultrasonography to look for clots in your branch points. We're looking at your femoral vein from saphenous down to the bifurcation of the femoral vein and following it just a little bit distally. And then we're looking at the popliteal vein in the popliteal fossa and looking for compression. Compression is the main thing that you look for. You can also double check your findings with color Doppler. If you have any questions, please feel free to email me. Thank you.